I'm just thinking of challenges that we have. Like, one is when we want to make a change to a CDK4/6 inhibitor. You know, I tell my nurse, you know, what we need to do. Of course, it's entered. We get the pre-authorization and everything. Everything's good, and then we expect it to get, you know, mailed to the patient from the specialty pharmacy. And some of our patients are reluctant to bother the doctor's office, so it doesn't come. And then they come back to clinic 4 weeks later, or 2 weeks later, you know, to get their checkup. They come because they had an appointment, but they hadn't started the medication.
Exactly.
That is very, very difficult. It happens with some of our folks that just kind of like have too many doctor's appointments, or just are maybe elderly, don't have the help at home, didn't have the second set of ears, and the and just people that are just reluctant to call the doctor's office, you know. But having being able to get it right there in the in the practice, obviously, you know, mitigates that, of course, you know.
Yeah, of course. If you have systems in place to manage that, it should mitigate it. But what you described is prevalent across the country. Most practices can only keep a certain percentage, maybe 50%, 40%, 60% of their prescriptions that are prescribed internally within their practice. And the majority, so to speak, need to go out to specialty pharmacy. And the practice can lose line of sight of that prescription and can diminish the continuity of care. So one of our emphasis within NCODA is trying to shore that up. It's certainly one of the COPE quality standards from ASCO. If you're a COPE certified practice, being able to have that line of sight on a prescription that leaves the practice, that goes to specialty pharmacy. There's a requirement.
It's hard to do.
It's very hard to do. It takes effort. There's some best practices that we've shared across our network to help practices get better at it. Because it's the best thing to do for patients.
Right.
Because that situation does occur where they show up and they haven't received it. You know, our practices can do it better, if no doubt about it.
Yeah, I mean, you just cut that. That's one less thing you got to track if it doesn't go outside. You know, a third party in there. You know, it's just much easier to keep it in house, basically, just from the practicality of getting it in the first place. You know, the next thing is the $15,000 box that sits in your closet because it's the wrong dose. So, you know, you see the patient back and they've got grade 3 or 4 neutropenia, and you have to make a dose reduction. Like on palbociclib or ribociclib, but the specialty pharmacy has already sent them their next month's supply, and we can't send it back. You know, and so then we have to make a dose adjustment, and we have to resubmit the prescription, and then takes a little while, you know, not long, but a few days to get to the patient, you know, but that's another possibility of another delay, possibly, because anything can happen, you know, and so then there's just a lot of waste, but also the patient has paid another copay, you know, for that as well, you know. And that's frustrating. That's really super wasteful. A lot of docs don't like that, you know, at all. See, that's one of the advantages of ribociclib, because you can, each pill is 200 milligrams. So you can go down from 600 to 400 without wasting. So that's very important, actually. But again, how does this work with the medically integrated? How can you guys help with that?
Yeah, so we developed, as I mentioned before, a quality standards, and there's 4 domains of the quality standards. One is foundational, and in the foundational quality standard talks about cost avoidance and waste. And one thing that a medically integrated pharmacy team needs to do or work towards is minimizing the costs associated with errant fills. And they can occur in 2 different ways. One would be if you're able to fill that prescription at your practice, to ensure that when to look within the EMR to see how the patient's doing, and not to automatically refill a prescription with the same strength, the same quantity, unless you get verbal okay from the physician, the prescriber, and also the patient, to make sure that they can afford it and the prescriber still wants to prescribe that. And if there's any differences, then you make adjustments to minimize any of that waste. And it's a timing issue, and it takes effort. And it really
Takes resources.
It takes resources. And so when you have that medically integrated team and you have commitment from senior leaders within your practice to devote time, energy, and effort to that, it can be done very well. And we track that, and I say we, and CODA as an organization tracks the cost avoidance that practices have taken out of the system by eliminating errant fills. Because as you described it, based on a timing, if a patient is to receive the therapy today, that has already, if it was on refill, it had already been sent 5 days ago, so that it gets there hopefully in time for the patient, which doesn't always happen. But in that 5-day span, a dose adjustment may have been needed, a change of therapy or a delay in therapy or a holiday may be required. And if we have control of that prescription at our practice, then that errant fill never happens. And so we track that on our website. We've got millions of dollars that we've saved healthcare providers and employers by being proactive and being medically integrated. The other situation is when it goes out to specialty pharmacy and trying to build in an infrastructure to try to prevent that errant fill. Now that's more difficult based on time fences, right, and milestones, because the specialty pharmacy needs to mail out a prescription a week or so in front of that. And so we try to mitigate that as best we can, but inherently, again, as you mentioned, because it's not in-house, it's more challenging to prevent that waste. And so we, like I said, we have metrics around that, and we have sharing of best practices on how to do that well.
Yeah, it's really incredible when I think about it, because the pharmacist or nurse navigator can look at the EMR and even look at phone calls in that have been documented about toxicity. They can see if there's been a hold. So that's important, because I better not fill, I better wait until the patient sees the physician to see if there's a dose adjustment, or give the doc a heads up. You know, hey, we're going to let you know here. We're going to take a look at this. You might need a dose adjustment here. We love the help.